Good morning. Let's wait for the others to join. Okay. Let's wait for the others to join. Good morning, everyone. Good morning. Good morning. Right. Let's wait for the others to join. Okay. Can we start now? Good morning, everyone. Good morning. Let's start. Today is respiratory emergencies. Okay, respiratory emergencies. Right. Respiratory emergencies. Let me know if the font size is okay at your end and if you can see it well. Okay, let me know if the font size is okay at your end. Right. So we can start now. Respiratory emergencies. Respiratory crash course. Okay. Yeah. So this is I mostly prepare crash courses for people who are about to write their exams. Okay. Yeah. So if you are part of today's session, then you should count yourself blessed. Yeah, because after today, the way you think, the way you see certain things about respiratory conditions will change. It's not going to take long. This is very short. It's a crash course, so we don't have to spend more time here. Okay, it's a very short lecture today. Uh-huh. Then I have also some questions, but I don't think we will do questions today. Okay, yeah. So let's start. Let's start. Right. So I always say when I do my crash courses or lecture notes, I always say that these notes support education and clinical review. In practice, follow your facility's emergency protocols, rapid response criteria, or authorized medication orders. Okay. Right. So when we talk about respiratory emergencies, like the way we did cardiovascular emergencies, we are not going to talk about every like every other condition under or every condition under emergency respiratory system. Okay, we are looking at the emergencies, the respiratory emergencies, those specific conditions that yes you must know, no matter what. This is a must. You must know. Okay, right. So first of all, respiratory emergencies. If the person is conscious, okay, or if the person can tolerate care, this is the orthopnic position that they sit in. Okay, the orthopnic position, and we can please let me know if you can see the slide well. Let me know if the font size is okay. If it is okay at your end, please let me know. Okay. Yes, let me know. I beg you. Right. So we have different forms of oxygen delivery systems, okay, or tubes. So we have the simple or the normal nasal cannula, which everyone knows. We've got a simple max. Okay, so I've added the sizes, the volumes under it. Okay, then so this one will take up to 6 liters, and this up to 10 simple phase max. Then we have the Venturi. So after this, then you go into Venturi. A lot of hospitals don't have Venturi. Okay, if you look at the Venturi max, most of the time it comes with this cord. Okay, yes, so know the difference. And also, uh, some most at times, the simple face marks, this place will be punctured. Okay, punctured, but it's if you look at the Venturi marks, instead of the puncture here, they have what cut it off in all these places. Okay, yeah, it looks exactly like the simple face mask, just that this one can deliver more oxygen to the patient, okay, and help with ventilation coming out, okay. Then we have the non-rebreather, with this bag under it, okay. Yes, going up to 20 liters. Going up to 20 liters. Right, we have this chest X-ray also here, okay, showing tension pneumothorax, okay, with all the collapsed lungs, okay, the diaphragm going down at this side and that, okay, then mediastinal shift, also going here, Right. So let's start everything. Today we are looking at, or by the end of today, everyone, including me, and you'll be able to recognize early and late signs of respiratory deterioration. Okay. You also be able to perform a rapid, you also be able to perform a rapid ABCDE respiratory assessment. We did it for cardiovascular, so we are going to do it for what? Respiratory system. Then also you'll be able to differentiate what is hypoxemic from what? Hypercapnic. Okay, respiratory failure. Okay. Identify common life-threatening respiratory emergencies. Then initiate appropriate oxygen, ventilation, and nursing interventions. Okay. Then you recognize when to activate the rapid response, calling the code. Okay. Or prepare for intubation. Okay. Then the last one, to reassess the patient and evaluate response. Okay. To treatment. Right. So what is respiratory emergency? The respiratory system, or the respiratory, when we say somebody is in respiratory emergency, is any condition, any condition in which the patient cannot keep the airways open. So you've got this is your airway. Okay. This is your airway. Okay. This is the airway. This is the airway. Then the alveoli is the small one. So this is the airway. Okay. Yes. Think out to your mouth. Okay. So take away the lungs. Okay. We have the airway. Then we have the lung. So the lungs too are there. So the airways connect. God, the one who created us. Okay. This is the lungs, and this is your lung. Okay. Yes. So one, you are unable to what? Keep this airway open like this. That is one. Somebody has a good lung. Somebody has no airway muscle or any structure, trachea, bronchia, whatever. Everything is intact. No cut, no break, whatever. Everything is okay. The nerves are connecting to the airway nicely, the cervical nerves. Okay. But somebody's airway is very closed like this. So between this airway and this airway, which one can take more oxygen? Definitely the bigger one. Okay, good. Secondly, a condition which the patient cannot move air effectively. Movement of air. Okay, movement of air effectively. Yes. So where is air coming from? I'm using the word air because what we breathe is air. 21% of air is what? Oxygen. Yes. So you breathe all these gases, okay? The inert gases, okay, helium and all those stuff. You breathe it through the atmosphere. Okay. So I am having a problem sending air down. Yes, sending air down. The body only needs what? Or it needs the oxygen. Yeah, nitrogen and all those gases are there to keep the airways and everything open. But you are having a challenge with what? Moving air down. What is causing that? Is it that the airway is blocked? It can be blocked by secretions, any object, children, adults, somebody swallowed, or this is your esophagus, always sitting behind. or at the back of your airway. Okay, somebody has swallowed a big ball of fufu. The esophagus is connected to the stomach. Why is the person choking, and why is the person having cyanosis? Okay, because the airway is so fragile and so malleable that soft that if something blocks the esophagus, it will put pressure. Most of the times, it puts pressure on the airway and it collapses the airway. Okay, so you realize the person cannot what, breathe. Aha. The person cannot breathe does not mean the person cannot bring oxygen, carbon dioxide out. The problem is taking oxygen down becomes a problem. Okay. Now the oxygen has got into the lungs. It has got into the lungs. Okay. Yeah. Oxygen has got into the lungs. The lung have to what? Transfer these gases to the pulmonary arteries and veins so that they send it. Please, I'm coming in. Okay. So that they send it. So the airway has done their own. They have given the gases to the lungs, the tissues. Okay. The lung have to what, or has to what, push the gases down to the bloodstream. Now the lungs has what, problems. It cannot push the gases down. Okay, that is another problem. So when you are in this state, we say what, you have what, airway crisis. Okay, yeah. Then secondly, okay, now the gas has been sent down. They are coming back in the form of carbon dioxide. Okay, so it has gotten here. When it got here, it has challenge of moving from here to here, or from the the lungs to what, the airways. Okay, yes. So removal of what, carbon dioxide too. So the patient cannot remove carbon dioxide. Then lastly, when we say somebody has respiratory emergency, it means the person cannot maintain adequate breathing without exhaustion, without getting tired. Okay, yes. So especially this last one causes is one of the main causes of cardiac arrest in children. Okay, yes. A child is having a difficulty in what, breathing, moving, chest excursion. Okay, the chest move up and down, up and down, up and down. Okay, people have respiratory conditions, diseases, okay, trauma, injuries, okay, that affects them, the respiratory muscles and the bones and all these ones, okay, from helping the chest to rise and fall, rise and fall. That is the breathing aspect, rise and fall, okay. So when it happens like that, some will be tired, they will be tired, and the respiratory muscles will give up. They can't help you. The bones will give up, the nerves will give up. Yes. So at that stage, you are saying what? You are exhausted. Okay. You are exhausted. So this is when we say somebody has respiratory failure or respiratory emergency, ask yourself which part of the respiratory system is the emergency coming from. Okay, good. So let's continue our journey. Right. So the patient may deteriorate from respiratory distress to failure, and finally arrest. So before we say somebody has respiratory arrest, there should be what? A distress. Yes. Then as time goes on, you become exhausted. And when you become exhausted, your system, the respiratory system begins to fail. Okay. And if you don't do anything about it, it will stop. Like the way the heart stops, it will stop. Yes. And in that case, we call it what? Respiratory arrest. It's not cardiac arrest, it's respiratory arrest. Yes. So anytime you meet someone unconscious on the street, the BLS algorithm, they will say check the cardiac, check if there is a pulse, if the heart is still working, or check if what the person is breathing. Okay, check if the respiratory system too is functioning. So we call it cardiopulmonary. Okay, resuscitation, or yes. So respiratory distress, patient is struggling but still can compensate. So they are having what increased work of breathing. They are putting in so much effort to breathe. Okay, putting in so much effort to breathe. That is what we call respiratory what? Distress. Yes, they are struggling to breathe, but they are still compensating. The muscles, the bones, the nerves, all are coming together. Sometimes the muscles will go and borrow other muscles. We call it accessory muscles of respiration, like the sternocleidomastoid and the abdominal muscles. An adult breathing with the abdominal muscles, trouble has come. Okay. Now, from this stage, we move to what? Respiratory failure. So, respiratory failure in school, we were taught that we have type 1 and type 2. Okay. Yes. So, respiratory failure, we are looking at what? The oxygenation, sending air down. Okay. Sending air down. Yes. So, sending air down like this. O2 is going down. Is what we call what? Type 1. Okay. And the type 2 guys, ventilation, taking CO2 out. Okay. Yes. Somebody has a problem with what? Sending air down, but carbon dioxide coming out is not a problem. So everybody or any respiratory emergency you see and where the problem is coming from. Okay. Yes. So at that stage, we call it out. You have what? Respiratory failure. Okay. Now, respiratory arrest. Breathing has stopped. The muscles are tired. They can't help you to move in and out. Chest excursions. Okay. Stop. Yes. In this stage, we say you have what? A respiratory arrest. We can never treat respiratory emergencies without going through the ABCDE algorithm like we do for any other system. The ABCDE is very important. You can't do emergencies without it. Okay, it helps you. So, like we did it for the cardiovascular and other systems, we are on respiratory. Let's look at it. So, airway, ask yourself, how will you know that somebody's airway is blocked? This airway, how will you know that somebody's airway? Take away the lungs, concentrate on the airway. Okay, can the person speak? Clear speech. You ask them. Okay, it is a good sign that, like, I'm talking to you. That's air, this carbon dioxide that is coming out, it will pass through a certain box here. A certain box here. We call it what? The voice box. Okay, the voice box. If something chokes me here and this carbon dioxide does not come out, or I have COPD and I can't bring carbon dioxide out, and I have exacerbation or crisis, okay, this voice box is intact, but this blockade is not making me bring out a lot of air, or carbon dioxide out to pass through the voice box for me to speak well. Okay, yes. So clear speech, hoarseness of voice and stridor, Giggling, wet. So yes, all these ones, a lot of secretions in the airway. It will not what eliminate the voice box. There will be a lot of secretions there. So when somebody is talking, you hear a lot of wet, like gargling, okay, wet voice, the stridors. This is an upper airway respiratory or emergency. So you hear all these sounds when somebody is, or inability to speak. It suggests what? Obstruction. Look for vomitous, blood, secretions, swelling, or a foreign body. So all these, so these are the things you look out for when you are assessing patients' airway. Okay, then you suctioning, you suction when necessary. Okay, sometimes you use a jaw thrust. So this is a chin lift. Okay, sorry, this is a chin lift. In anesthesia, chin lift, jaw thrust, head tilted to the left. Okay, so if you look at this muscle, sorry, this bone, okay, yes, lift it up. It is just sitting on maxillofacial. So this is the center. There is one bone here called the maxilla, and this is the mandible. Okay, they are sitting on it here. They are not together. There is no screw connecting them together. It is just a hole like this, and this one will come and form a socket here. And there are a lot of cartilages here with synovial fluids. Okay, so you can lift it up like this. If you lift it up, it stretches the airway. So it will be more patent. Person is having a lot of secretions. Okay, lift it up, it will stretch and open the airway. Yes, so we call it the jaw thrust. Especially people with what spinal injuries that the respiration has stopped. Then you prepare airway equipment early. So airway equipment, what are the things in airway equipment preparation? The ABCD is very important. So the A, what will keep the airway open? Equipment that will make the airway open. The oropharyngeal tube, the nasopharyngeal tubes, the ET tubes, and the LMS. Yes, these are the things that will keep the airway open. Yes, ask yourself, which tube can I put in somebody's nose that will make the nose big, the lumen bigger? Which tube can I put in somebody's mouth that will make the airway clear and bigger? So those are what we call the airway. Now the breathing. What equipment can I use to push oxygen down? Or what equipment can I use to bring oxygen out? So we have what the simple max, we have the nasal cannulas. Okay, they help in breathing, okay, to deliver oxygen. Yes, we go up to, so the CPAP machine is there. We have the BiPAP machine is also there. We have, depending on the condition the patient presented, okay, we have the ventilator to what? To push air and bring it out. Yes. So all these ones, then we have the ambu bag. Okay. Yes, to push air down, the ambu bag for both adults and children. Now, so we are preparing the airway equipment. I'm showing you the easiest and the easiest way to prepare airway equipment in when it comes to emergencies. Okay. Now the circulation. The circulation. I will not talk about circulation because I mean we don't need circulation, but in anesthesia or in theater, in circulation, your IV line will come. Okay, your IV fluid will come. If you want to warm your IV fluid warmer. If you want the IV fluid to go so fast, you talk about what the pressure bag all these other equipments. Okay. Then the D talks about what the disability. Uh, so oxygen, I mean the GCS and all those stuffs. Yes. So let's look at the sounds. How to prepare airway emergency sound, or the sounds you hear that will tell you that this person is in what airway emergency. Okay, so you can hear stridor. Stridor, yes, everybody knows that stridor is an upper airway obstruction. Okay, somebody is snoring. When you are snoring, is two structures we look at: the neck, the structures of the neck, or the mouth. Inside the mouth is the tongue, but the neck, okay, what the structures you see outside, is the same thing you see inside. So if somebody's neck is very long and short, it means that the muscles are not that much inside. Okay, yes, and this and vice versa. So the soft tissues of the neck, and the tongue, it rolls back, or when you are sleeping, it becomes flaccid. So they block the airway. Uh-huh. So it causes what? Somebody is having gurgling, wet voice. Don't let this English worry you. It is wet voice. Okay. Wet voice. So this is the voice box. If your airway or the esophagus is wet, all of them pass through here. Okay. So if too much wet, this voice box will be wet. So when air passes through, you'll be hearing that wet voice style. Okay. Yes, especially if you want to assess for dysphagia, okay, for GI system. So we have, is it blood? That is oozing into the airway. Is it secretions or is it vomitus? So these are the things you are going to. If you are able to confirm any of these things, you suction it out. Okay. Then wheezing. Wheezing is the same as the stridor, just that wheezing occurs in the lungs. Sorry, yes, and the lower heart, the lower airway, the lower airways. So wheezing sound, this side, the wheezing. Okay, it's just like the stuff. It's what a lower airway problem. Okay, then we have crackles. You can't hear crackles in the airway. You hear crackles in the lungs. So those of you say that the airway, I'm hearing a lot of crackles in the airway, is a wrong English. Okay, it's a wrong English. You hear crackles. Crackle is a problem of the alveoli, okay, where there is a lot of fluid accumulation. So the right lung is divided into three. We have the upper lobe, the middle lobe, and the lower lobe. And the left lung, because of the heart, is divided into two, the upper and the lower. So if you look at the right side, the upper, this is the upper, this is the lower, below your nipple. This is the lower, and this is the middle, and this is the lower here, the lower aspect. Yes. Then here and here is the upper and the lower for the left side. Good. Now, so you use your stethoscope. You can't hear wheezing with your ears. Use your stethoscope to help you to to hear, okay, wheezing sounds, okay, and crackles. Silent chests. It's what? Minimal airflow. This is a life-threatening emergency. Okay, that shows what? Obstruction. So these are the things you have to also consider when you are doing your airway assessment. Now let's go to breathing. I've told you that breathing, we are going to look at breathing. We are looking at the muscles, one, okay, and the bones and the nerves. Okay. Yes. Most of the times they don't consider the nerves, but the muscles and the bones. Okay. So we have the bones here, and we have the muscles in between. Okay, the muscles in between the bones, you call the intercostal muscles. Then the diaphragm. These three, these three guys should be able to help you to breathe. You don't need any help. Every human being on earth, okay, except only children and babies, they sometimes borrow. Most of the times babies borrow, or there's abdominal muscles to help them to breathe. So if you look at, if you have a child and the child is breathing, some, you look at their abdomen, you see the abdomen moving up and down, up and down. So if you are waiting for a child's chest like to move up and down, up and down, up and down, you are sometimes making a big mistake. Okay, you look at the abdominal muscles because they borrow the abdominal muscles a lot. But for we adults, we concentrate on these three. Okay, the bones, the intercostal bones, the costal bones, the intercostal muscles, and the diaphragm. And the diaphragm. So if you are in serious respiratory crisis, okay, you now go and borrow what, your sternocleidomastoid, that muscle that is connecting from your neck to what, the mastoid. Okay, yes. So you are going to borrow this one. Then you also borrowed what, the respiratory muscles, the abdominal muscles to help you to breathe. Yes. So respiratory rate, or when we talk about breathing, we are looking at three angles of breathing. We look at the rate, the rhythm, and the volume. Okay. Just like the way we do for cardiovascular, the same thing when it comes to breathing, the rate, rhythm, and volume. Rate, rhythm, and volume. Rate, rhythm, and volume. Okay. Yes. So the rate is what everybody, every nurse in the world has been doing every 1 minute. How many times was the lungs able to move up and down, 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 up and down? So they will say that, oh, within 1 minute, you were able to move 16 counts. So the count is one, go. It's in and out. This is one count. In and out. This is two count. In and out. This is three. A lot of people make mistakes. They count it in, they'll say one. Out. Breathe in, they'll say one. Breathe out, they'll say two. This is wrong. This is a cycle. And the cycle must have a breathe in and a breathe out. So this is one cycle. Okay, yes. So these are the things you should know. Now, that is the rate. Now, the rhythm, just like the way we have arrhythmias. In respiratory system too, we have rhythm issues. Okay, this arrhythmias, whatever, anyhow you want to describe it. Okay, yes. So I'm breathing in and out in that space of that 1 minute. How was what I was able to breathe in and out, breathe in and out, breathe in and out. I breathe in and I held it there. It took me like 4 or 5 seconds, then out. Then breathe in. Then I hold for a long time, or breathe out. I hold for a long time. So it is not consistent. Okay. The rhythm is what, the consistency of the moving in and out, in and out, in and out, in and out. So if I'm not consistent, it means that what, I am having issues with what, rhythm, breathing rhythm. Now the volume, that is the depth, the volume. Okay, this is my back, and this is what, my chest. Okay, I want to breathe in. This chest was able to move like this. Okay, It was able to move from this angle to this level to this level. Breathe in. So you breathe in. You are able to accumulate, okay, a lot. So you see the space, the depth. Yes. But somebody with a stab wound, all these ones, they can't expand a lot. Somebody with severe pneumonia, they can't expand their chests a lot. Okay, because the respiratory muscles are in big trouble. Okay, they can expand their aha. So when it happens like that, you are not able to accumulate or get in more oxygen. Okay, so you start having what issues with what oxygenation. Okay, now you look at the chest symmetry. The chest symmetry for breathing. So chest symmetry means divide the chest into two. Divide it into two in the vertical form. Divide it into two. So this is the left side. This is the right side. If I breathe in now, if you are sitting down, breathe in now. Breathe in. If you breathe in, the left chest and the right chest, they should move together. Okay, they should move together. If you want to breathe out, they should breathe out. They should come back together. If I say breathe in, you breathe in and your left chest moves, okay, before the right moves. We call it asymmetry. So people, children with broken bones of their chest, okay, broken bones, you realize that whilst one side is breathing out, another side is sucking in. Okay, it's sucking in. So we call it what asymmetry, chest expansion. Okay, good. Then work of breathing. I mean, how easy you are able to breathe and all those stuffs. Use of accessory muscles, retractions, ability to speak, breath sounds, SpO2, all these ones we know. Skin color and mentation, then end-tidal CO2 when available. Okay, end-tidal CO2 when available. Okay, so expose the chest in emergencies, expose the chest while the patient is what? While maintaining privacy, especially if you are dealing with women. Expose the chest while maintaining what? Privacy. Position the patient upright unless contraindicated, maybe spinal injury, cervical injury, all these ones. Okay. Let's look at the circulation. Somebody will ask you why are we concerned about circulation in the airway? Yes, whatever happens to the respiratory system affects the cardiovascular. So they are twins. They are twin systems. We call it the twin systems. So whatever happens to respiration, sometimes if you don't treat it, happens affect what the cardiovascular system. So we go and check what is the pulse doing, what is the blood pressure doing, what is the temperature doing, the capillary refills, okay, the cardiac rhythm, the perfusion, peripheral perfusions. Is there any sign of shock? Is there any jugular distension? Yes, sometimes it helps us to what diagnose some of these conditions. Is there any IV access and all those ones? Okay. Severe respiratory problems may cause arrhythmias or dysrhythmias, hypotension, and cardiac arrest, especially tension pneumothorax. Okay. So that is what you should know. Then disability. I've told you that disability is about what? The brain. The brain. What is the brain doing? Is it on the upper side? Oh, sorry. The brain. What is the brain doing? So is it on the upper side? Okay. So this is the normal, this is the upper, and this is the downer, the lowest. So this is my brain. Okay. You were doing assessment. You realize that the patient is exhibiting upper brain functions, agitation, okay, restlessness, inability to maintain concentration, all those ones, or they call them the uppers. Then the downers, okay, the downers, lethargy, okay, uh, stupor or coma, okay, yes, all these ones are those things that will bring the patient's concentration down. Okay, loss of consciousness. Okay, loss. So all these ones you do. How are you going to? You can. How are you going to see these stuffs? You look at the patient, then you make or sorry. I look at my patient. Okay, you look at your patient, you see the uppers and the downers. Okay, but if you want to know proper what the brain is doing in emergency, go with your AFPU. I've told you this, or the GCS in emergency. When the patient becomes relaxed and they send the patient to message or whatever ICU for continuous monitoring, then you do your hot in-depth neurological assessment, in-depth neuro assessment. Okay, assessment. I've told you this and I'll continue telling you this over and over. When you have emergencies, disability, me personally, when I have emergencies, I do this. After the patient alert, is there verbal response? Okay, is there pain or what? Unresponsiveness. I'm done. 5 seconds. I have my results. Somebody will be like, oh, I want to be upset. So let me do what? GCS. GCS is fine, but GCS can take waste time in serious emergencies. Okay, yes. So these are the things. Restlessness, anxiety, and confusion may be early signs of what? Hypoxemia. Drowsiness can indicate hypoxemia and rising CO2 or exhaustion. Okay. Now let's go to exposure. Exposure. Yes. So you naked them from head to toe. A nurse must have a scissors to cut clothes. Okay. And those stars, naked them from head to toe. You check from head to toe. Is there any skin break? Is there any cut? Some people, yes, the person is having respiratory emergencies. Okay. Respiratory emergencies. But how is there any related condition attached to it? Okay, so is there any trauma? Is there any rash or angioedema symptoms? Is there any burns, sooting, singed nasal hairs? How about their legs? Are they having leg swelling for DVT? How about fever? Is the temperature high? Is there any? Okay, then medication patches, drug paraphernalia, okay, or possible poisoning. So all these ones will affect. Now let's look at the red flags that you must act immediately. Okay, when you see any of these signs, activate what? The rapid response or call for the emergency. Silent chest, stridor, apnea with gasping and irregular respiration, especially children. Severe respiratory distress or rapidly worsening breathing, respiratory rate is crashing. Okay. Inability to speak, asthmatics, they will come. COPD, they will come. Okay. More than one or two words. So if asthmatic comes to your clinic, don't ask them closed-ended questions. No, we don't do that. Questions that will demand yes or no. Yes. Are you okay? Yes. Do you live in this town? Yes. Do you live with your parents? Yes. Those are all close-ended questions. Ask them questions that will make them use one or two or more words. Okay. So we have what? So many questions. Can you tell me what happened? Okay. Okay, what were you doing before this incidents? What were you doing? Yes. So all these ones, look at what a patient who is cyanotic, sudden decrease in consciousness, exhaustion or decreasing respiratory effort, saturation remaining below target despite giving a lot of oxygen. So somebody is having saturation of 82, 77. Okay. It has been here. You have given oxygen, position patient, done your door trash, chain lift, everything. Airway is clear. You listen to the checks. I mean, yes, call the ambulance or call the rapid response team. Okay. Severe bradypnea or extreme tachy, unilateral breath sound, air is not moving to both sides equally, okay, with hypotension, that is tension pneumothorax or pneumothorax, tracheal deviations, that is the tension aspect, hypotension, dysrhythmia, or signs of shock. All these ones you should what? Call the rapid response or the emergency team, okay. Yes. So the note for this is a decreasing respiratory rate is not necessarily improvement, especially the asthmatic guys. The fact that their respiratory rate, somebody came with respiration rate of 34, 40. Okay. The fact that it has gone down to 22, 20, 16, 12. You were within some few minutes, you were 34. Now you are 12. Okay. Yes, it is not necessarily improvement. A distressed patient becoming quiet, drowsy, or breathing more slowly may be entering a respiratory arrest. They are getting tired. The respiratory muscles are getting tired. Okay. The respiratory muscles easily get tired in crisis. The same as the heart muscles, they also get tired in crisis. And when they get tired, they stop working. They stop working. So this is what you should know. Okay. We know oxygenation and ventilation. Okay. How will I know that I am having what? An oxygenation problem? How will I know that I'm having oxygenation? So, oxygenation, I mentioned earlier on that pushing air down, the concept of air going down is what we call oxygen. Because when air goes down, oxygen will follow it. O2, 21% will follow. Yes. So, oxygen. How will you know that this respiratory emergency I'm getting, this patient is having what? Oxygenation problem? Saturation will drop. Or if you do your ABG, ABG analysis, ABG analysis or VBG, if if you are not good with getting arteries to tap blood from it, use the veins and get your blood gas and gases. Okay, so you see that the partial pressure of oxygen has dropped. That should tell you that what I'm having respiratory type 1 failure. If I don't treat these patients, they will get arrest. Okay. Cyanosis. Oxygen is not coming down. If oxygen is not going down, if oxygen is not going down, how will this oxygen enter the bloodstream? And the bloodstream will take it to the body. So the body is not getting what? Oxygen. So cyanosis. Is it central or peripheral? Restlessness, confusion, that should tell you that the brain is not getting their oxygen. So the brain is also getting in trouble. Then tachycardia, the heart will try to pump. This is a compensatory mechanism. We call it reflex tachycardia. Okay, yes. So all these ones will come in. It's a clear sign. NCLES, you see it when you get respiratory conditions. You will see clearly that, oh, I am having trouble. Okay. Look at some of the conditions that can easily launch a patient to type 1 respiratory failure, pneumonia, pulmonary edema, pulmonary embolism, and acute respiratory distress syndrome. So these are examples of conditions that can. So when you see, if NCLEX wants to test you in this angle, okay, and they want to end at respiratory failure, then start thinking about type 1, type 1, type 1, type 1, all the medical conditions that will affect oxygen delivery to the system. Okay, let's go to the hot CO2 coming out. Yes, oxygen has gone, help the cells to do whatever they want to do, their metabolism, ATP, production, everything. Carbon dioxide is now coming back. It's coming back. It's coming back. Okay. When carbon dioxide was coming back, it has been blocked. So it has started accumulating in the system. Accumulating in the system. Accumulating in the system. Meanwhile, the person is breathing oxygen down, but the carbon dioxide is trapped. It's not coming out. Okay, so if I do my ABG analysis, I will see what the partial pressure of carbon dioxide going what up, the CO2 rising, CO2. So if you do your chemistries, CO2 rising up. Okay, yes. Respiratory acidosis. That should tell you that what a lot of carbon dioxide is sitting in the airways and what the alveoli. So you have a lot of. Okay, what is the normal carbon dioxide level? Yes, shoot your answers. Normal CO2 levels. Yes, I want to know the answers. Every normal human being, normal CO2 levels. Yes, I want to know. Shoot your answers to the chat box. Yes, normal CO2 level. Yes, normal CO2. Good. So 35 to 45. Okay, 35 to 45. Okay. In the blood, I will see this. In the blood, I will see a lot of, if I take your blood from an artery and I give it to the ABG analysis machine, I will see higher levels of CO2 in the blood. How about the lungs? Do I have to pass a tube down and go and fetch CO2 sitting in my lungs like COPD guys? Do I have to do that? No. So how will I be able to know that CO2 is super, super, super high? CO2 is super, super, super high here. Okay. We use a certain machine, we call it the capnograph. Or capnograph is the picture. Capnometry. Okay. Yes, the capnograph. I can give you something to breathe out. Okay, let's say a face mask, LMA, or ET tube. You are breathing through that tube out. You are bringing out CO2. So when the CO2 pass through, this capnograph has sensors. There's some light in it, sensors. So when the CO2 passes through it, it will calculate the percentage or the amount of CO2 passing through. This is a reflection of what is sitting in the lungs. So you are taking a patient, and those of you who work in theater, okay, you are taking a patient for long surgeries, neurosurgeries, orthopedic surgeries, so many hours. The patient will be lying down on the bed, hypnotized. Okay, good. So you measure their CO2s in the lungs, CO2s in the lungs. Then you tap, if you want to know the CO2 in the blood, the ABG analysis. Okay, you do that. How will a patient, or what are the signs and symptoms the patient will exhibit? This patient, if they are conscious, they will start complaining of headache. That should tell you that we have a lot of CO2 going to the brain. Weakness or drowsiness. Shallow or slow or ineffective breathing. Shallow, slow, or ineffective breathing. Okay, so let me explain. Let me take my time to explain this to you. Okay, shallow or slow, that should tell you that what? Shallow or slow or ineffective breathing. We mostly see this in what? COPD guys. Okay, and if you're not careful, they will be unconscious. This is my brain, and this is what? My lungs. Okay, with the muscles and everything attached to it. And this is my bloodstream. Okay. In the bloodstream, there are CO2 coming from the cells. This is the cell. They will go to what? The heart, and the heart will pump some to the brain. When this CO2 gets to the brain, oh, sorry, they said I've muted myself. I've not muted myself. Please, can you hear me? Let me know if you can hear me from your end. Okay. Right. So if this CO2 gets to the brain here, there is a center here. We call it the respiration center, the ref center. Okay. Yes. That will capture, the CO2 will trigger the center, and the center will send impulses to your lungs that breathe. Okay, breathe. So the higher the CO2 levels here, okay, in a normal patient, the higher the CO2 levels in the brain, the higher the respiration rate. Okay. In COPD, or let me say it this way, if the brain keeps getting higher, every minute, every second is getting higher CO2, what will it do? It will now compensate that, it seems the body is trying to depend on what? CO2. So let me now tell the lungs that, hey, instead of the hyper or whatever, the tachypneas, instead of the rapid respiration rate, guy, get down, slow down. Now, yes, if I get higher CO2, I will what? I will not tell the lungs to breathe. That should tell, so the brain will condition itself. Yes, it will condition itself that, now the body has adjusted that it will depend on CO2 for survival. So let me also tell the lungs that you don't have to breathe. You don't have to breathe. This thing will continue for a long time, especially COPD patients. COPD patients. So in COPD patients, they are having issues in bringing carbon dioxide out. Their problem is not about taking oxygen in. Their problem is about bringing carbon dioxide out of the body. So when you take COPD patients, especially when they are in crisis or exacerbations, they have a lot of CO2 in their system. So what would the brain do? The brain has switched. The brain for COPD, for them to survive. I don't know how the brain is able to detect that for COPD patients alone. The brain switched from depending on CO2 to oxygen for COPD, because the brain has conditioned itself that COPD patients are always retaining CO2. So if I want to use the same physiology I use for every other human being, that I will depend on CO2 for them to breathe, then I'm not being fair to COPD guys. Okay. So let me now take what? The lower side. In other words, the brain receives oxygen, O2, and CO2, okay, from the bloodstream. So in a normal human being with no COPD like you and I, our oxygen is always high in the blood, okay, and our CO2 is low in the bloodstream. So the brain will depend on the lowest concentration to tell the lungs to breathe. That is what the respiratory center does. But in COPD people, their CO2 is high, and especially when they are sleeping, okay, and their oxygen is low. So instead of the brain to depend on the CO2 for them to breathe, the brain will now depend on what? The oxygen for them to breathe. Yes. And it will tell the lungs that, hey guy, you don't have to breathe so fast. Okay, take it slow, take it slow, take it slow. Okay. In the bloodstream of COPD, their oxygen is low. So if I want to put a saturation probe here and I measure the concentration of red blood cell that goes through that saturation, I will always get a low CO oxygen. Okay, so they do very well in what? 88 to 92 saturation. Unlike you and I, our brain will be expecting us to be certain or be having a saturation of what? 95 to 100. COPD patients, the brain keeps them here and they are okay, and there is balance. Now, a nurse who doesn't know this will go and give higher concentrations of what? Higher concentrations of oxygen. Higher, you give them a lot of oxygen. Now you have increased the oxygen concentration in the blood. Okay, when you increase the oxygen concentration, the bloodstream for COPD patients will be like, oh, where are we going to keep all this excess oxygen? Okay, now all these blood vessels that were closed in sending blood to areas of the lungs that were also closed, the atelectasis areas, the blood vessels will push more blood there. But remember, COPD patients, they are always retaining CO2. Yeah. Okay. So sending more blood to this atelectasis alveoli, it means you are hot, sending CO2 there. And that CO2 will go and knock off this oxygen ability in their brain. And COPD patients, you see them sleeping. If you give them a lot of oxygen, sleeping, some will become drowsy, some will become unconscious. When they begin to exhibit these signs, it means that you, the health worker or the nurse, you are knocking off, you are failing, you are destroying the brain's ability to rely only on oxygen for them to breathe. We say that you are knocking off the hypoxic drive, the hypoxic drive, the hypoxic drive. Yes. So COPD patients, they depend on hypoxia for survival, but you and I, we don't depend on hypoxia for survival. That is it. So it is the hypoxia that drives them. So if you go and try to correct that hypoxia, yes, it means that you are knocking it off, you are destroying it. What are some of the conditions that can have ventilation problem? Opioid overdose. Somebody has been taking fentanyl, morphine, injecting it, morphine. Yes. Why do they die? They don't die because taking in oxygen is their problem. They die because they bringing out the CO2. So they will end up getting what? A lot of CO2. And CO2 is an acid. So you get what? Acidosis and die. You shift the pH out of the normal range and you die. Okay, yes. Somebody is having what? Neuromuscular weakness, all these Alzheimer's, all these NMS, okay, yes, all these neuromuscular issues. Somebody has been given neuromuscular blockade medication, vecuronium, atracurium, pancuronium. Okay, yes. So all these ones should tell you that no, you are going to retain CO2. Yes. Somebody, children, before children will get cardiac arrest, they breathe more on their respiratory muscles. I told you that children borrow even their abdominal muscles to help them to breathe. If you have a child, when they are breathing, look, watch their stomach. Okay. When the muscles get tired, that is their end. And you don't help them and you don't resuscitate them, they will get arrest and it will stop the heart. Okay. So you not get, when we say a child has gotten cardiac arrest, it is not because the child was having atrial fibrillation or the child is having angina or the child, those things that not occur in children. Their respiratory system will fail and the heart will fail. That is it. That's their end. Okay. So those of you who will be working in pediatric units, children, that is their own. Yes. So a normal SpO2 does not guarantee adequate ventilation. Take note. A normal SpO2, the fact that you are seeing a lot of oxygen passing through or moving with the red blood cells in the body, ask yourself, okay, oxygen is cool. How about, is there any device we can help to tell that this patient is what is bringing out the CO2? Yes. A patient receiving oxygen can maintain an equal and perfect SpO2, but still the carbon dioxide will be trapped. That is where a lot of people fail. Okay. Yes. You're having good oxygenation. Ventilation is a problem. Okay. Right. So that is it about ventilation and oxygenation cascade. Now let's look at what the oxygen delivery and escalation. When a patient comes with respiratory emergencies, always start from what? Or if a patient is having, for you to know that this patient is failing. Yes, I can't breathe, I can't breathe, I can't breathe, I can't breathe, I can't breathe. Okay, let's give you nasal cannula first. This one will give you sometimes up to 6 liters. Cool. Then you give. Then still I can't breathe. Saturation is dropping, whatever. Or even saturation is high. Okay. Saturation is normal, but patient is still complaining. I can't breathe. I can't breathe. I'm feeling uncomfortable. I can't breathe. But saturation is normal. Your machines, everything, you have changed the probe from one hand to the patient is okay. Change simple face mask. It's still failing. Patient is complaining. Let's go to what? Venturi. Increase the oxygen flow rate. Okay. Let's go to what? Non-rebreather. When we get to this stage and you are still having hypoxemia, or you are still having issues, we now switch you to what? Some in the community, or if in the hospital, I mean, you are now going to call emergency response, call this, is going to delay, patient will crash on you and die. So like in most of the hospital, every room has what ambu bag. Every patient room has ambu bag. So when you connect to the oxygen, then you bag. You don't need rocket science to know how to do ambu bag. Okay, yes. If this one fails, we go buy pap. Most of the times we don't do this, okay, but some people do. Buy pap sharp. Okay, if BiPAP fails, we have to intubate you no matter what. So some guys will be drinking, some guys will be failing, drinking morphine and all this, overdosing themselves. If you are not careful, you end up in ICU. Okay, they need to protect the airway and help with what breathing. Okay, so for most acutely ill adults without risk of hypercapnic respiratory failure or type 2 respiratory failure, a commonly used target is 94 to 98 oxygenation or saturation. For patients with COPD or another risk of CO2 retention, let's say drug intoxication, or a provisional target of 88 to 82 is commonly recommended pending blood gas results and analyze orders. So this is according to the British Thoracic Society. Okay, yes. So these are the things you should know. Don't go and open oxygen way that you want to concentrate a lot of oxygen in COPD crisis. You knock off hypoxic drive. Okay, yes. And according to the American Heart Association and BLS guidelines, they said that if the patient has a pulse and is not breathing normally, so you see one condition, but everybody is bringing their thoughts. If the patient has pulse and not breathing normally, you open the airway, okay, and clear, you suction, clear, begin your bag valve ventilation, give appropriate one breath every 6 seconds. Okay, recheck your pulse, and if the pulse is lost, begin what? Your CPR. Avoid excessive ventilation because it can cause gastric inflation. If your stomach becomes full, you are at risk of what? Vomiting and aspiration. Okay, good. Now let's take the conditions one by one. This is why we are here today. Okay, one by one. So major respiratory emergencies. Asthma. Asthmatic patients will come to your clinic with what? Wheezing, coughing, chest tightness, tachypnea. If NCLEX wants to test you, they'll give you some of these signs and symptoms. Prolonged expiration, difficulty speaking, reduced peak expiratory flow rate, and what? Hypoxemia. Okay, yes. If they launch into this indicators, that should tell you that no, their condition is getting worse. Asthmatic patient becoming cyanotic. Their mental status is changing. They are having silent chest. Silent chest is even far. Okay. Poor respiratory effort, work of breathing is very slow. Hypotension or bradycardia. Okay. Normalizing or rising partial pressure of carbon dioxide in a severely distressed patient. Okay, yes, especially asthmatic. Be careful. Be careful. Okay, so a normal or rising CO2 can mean the patient is no longer able to ventilate or they are tired. They are tired. So these are the things you should know. Okay, so what are you going to do? What is the immediate management? Asthmatics, sit them. Position is very important. Eh? Position is very, very important. This is the area where a lot of the kill banks, they, I don't know, sometimes is the way the question is also being put. Some will say give oxygen before you position. Some will say Position before you give oxygen. I don't know if you have met this scenario before. Yes, positioning is the most important thing. Positioning, positioning. Why am I saying that? Assuming you go and meet a patient lying down and complaining, I can't breathe, I can't breathe, I can't breathe, I can't breathe, I can't breathe. Okay, this is the bed in a supine position. I can't breathe, I can't breathe, I can't breathe. Okay, will you go and look for oxygen and come and put it, throw oxygen on them? Okay, yes, you have thrown oxygen on them. Okay, is it advisable to throw oxygen on this patient in this supine position in a respiratory distress patient? That is the question you should ask yourself. Okay, that is the question you should ask yourself. Definitely, before you even go and get the oxygen, you definitely lift their head up so them to sit down like this. So sit upright, apply oxygen, administer inhaled short-acting bronchodilators, albuterol. All these bronchodilators that start with what? A vowel, a vowel, short-acting, albuterol. Okay, this is short acting. You can't use this medication on med-surg units. Okay, why? You can use it, but in a patient who are stabilized, we don't give them albuterol. We use this for emergency conditions. Okay, yes. You can add inhaled hypertropium in severe hot exacerbation. Okay, so you see the eye. Good. So the A, you know your vowels now, A, I, E, U, whatever. Okay. Give systemic corticosteroids early to help with what? Any inflammations, airway inflammations, you settle it down. Then you give, before they were not giving, but they have seen that magnesium will come and stop all nonsense. Okay, magnesium will calm the muscles down. And we ask ourselves, why are we giving magnesium? Why are we giving? I always get confused with this. Why are we giving magnesium to, where is it? Why are we giving magnesium to what? To asthmatic patients? Because when you take the airway of every human being, we have the inner lining, we call it the mucosa. After the mucosa, there are muscles. Okay, so the magnesium sulfate is going to the muscle. The magnesium sulfate is going to calm down the muscles so that their spasms will be stopped. Yes, their spasms will be stopped. How about hydrocortisone, the steroids, methylprednisolone, and all those ones? What are they coming to do? They are coming to the lining, the carpet. We call it the mucosa. Okay. Under this mucosa, there are mucous membranes. They call it the goblet cells. They are like pots. They are holding the mucus, the phlegms. So anytime you get respiratory allergies and respiratory all these ones, like they swell, they become big. When they become big, they can become big to the extent that they will burst, they will rupture. When they rupture, then you begin to what? Secrete, release the secretion in the airway. Release the secretion in the airway. Okay. So the hydrocortisone and all these steroids, okay, will come and what? Will come and relax all those inflammations. Relax it. Relax it. Relax. So if you understand the physiology of asthma, you know how to treat asthmatics. Okay. You know how to treat asthmatics. So max sulfate. But you are giving max sulfate. Remember that max sulfate you give, it is going to every muscle in the body. So you are giving max sulfate to treat asthmatic, but you realize that the patient is becoming weaker, respiratory muscle, DTR, deep tendon reflexes are dropping crazily. You stop the max sulfate because the max sulfate is overly crashing your muscle activity. Okay, so otherwise you get a wide QRS complex. And you get what we call a torsade de point. So wide QRS complex, a little shorter, then wide QRS complex, a little shorter. So it's a combination of what? VFib and VTAX. Okay, good. So these are the things you should know. Then you put the patient on EKG monitor because of this guy, because of this max sulfate. You put the patient to know what is, because the heart too has muscles. Max sulfate will go there. Aha. Then SpO2, the mental status, the disability assessment. Okay, you prepare for advanced airway in case of deterioration set in, depending on what your GCS and your AFPU says. Okay, yes. Never in your life sedate a struggling asthmatic patient unless sedation is part of the controlled airway management. Okay. Severe asthma exacerbations required urgent care and may be fatal. Yes. Asthmatics easily hot switch. Now, COPD. I've done a lot about COPD. COPD will come with what? Increased dyspnea, increased sputum amount or what? Release of more sputum. Wheezing and diminished breath sound, prolonged expiration. We call it what? Wheezing on expiration. Their problem is about bringing CO2 out. Prolonged expiration. Okay. And they use the accessory muscles a lot. Yes. Aha. Okay, they use their accessory muscles a lot. So these are the things you should know. They build a lot of CO2. They easily become confused, drowsy in severe CO2 retention. Severe CO2 retention. I've explained the physiology to you. Okay, sometimes the nurse will think that, let me give a lot of oxygen to COPD patients. You give a lot of oxygen, yes, saturation has increased to 98. What does it mean? I told you that in CO2, in COPD, when you take their lungs, half, example, half is not working, is dead. The alveoli, they are collapsed, they have closed. If they open, they say open alveoli like this, but collapsed lung is like this, flat. It's flat. Okay. And half is working, is alive. That is COPD patient. Okay. So the half that is dead, the circulatory system doesn't worry itself to send enough blood there. It only sends a few blood there just to keep these cells here not dead totally, not I mean ischemia, no. So they send more blood to the part that is working and less blood. But what is the nurse doing? One nurse went to give a lot of oxygen. So when the oxygen gets to what? The bloodstream, O2 gets here. The body will be like, where am I taking all this oxygen to? Okay. Now, okay, I have to store it. If I have to store it, I will store it in what? The lungs. So this part that were not supposed to send a lot of blood to the dead body, the heart will now start pumping more blood to this place and more blood to this place. And that blood that is coming to this place is coming with CO2. So the CO2 will cross and come inside or get inside the lungs. Now the CO2 is trapped here. It cannot come out. The brain will detect it. Okay. Yes. This CO2, some of them will mix and still enter the blood. So you realize that their CO2 is rising. At the same time, the nurse is also giving a lot of oxygen to rise it. Okay. So what now happened? The brain, the CO2, a lot of CO2, when it gets to the brain, they begin to what? It will reduce the brain function. So you see that you'll be sleeping, okay, drowsy, and all that. This is what happens to CO2, guys. Yes. So don't give a lot of oxygen. When you give oxygen and their saturation gets between 88 to 92, whichever level you got, stay there. Let's say I'm giving 2 liters. It has increased the SpO2 from 82 or 84, whichever number, to 88, 89, 90, 91, 92. I'll remain at this. Don't say you are going to increase it to 5 liters. You are building oxygen, and the patient will die on you. You will think they are sleeping, but they are dying. So upright positioning, you give controlled oxygen because of the target. Okay, yes. Then administer short-acting bronchodilators with or without ipratropium, depending on the crisis. You give your systemic steroids, okay. Then you do your ABGs, chest X-ray, you do your laboratory studies. If there's any infection, administer your antibiotics, okay. You consider your CPAP and the BiPAPs, okay, for acute hypercapnia. It will help to bring out the CO2, especially the BiPAP, okay. Prepare for intubation, if indicated, okay. Do not withhold oxygen from a critically hypoxemic COPD patient. Because of that, some nurses too will say that, oh, I don't want to let this patient die, so I'll not give oxygen. No, they need the oxygen, but they don't need it plenty. That is it. Okay. So you give, when you give and the saturation rises and maintain in the target range, stop. Wherever you are, stop. Okay. Keep it there. Don't stop the oxygen. Keep it there and reassess your blood gas analysis. Okay. Another respiratory condition we meet is pulmonary embolism. The patient will come sudden, the unexplained dyspnea. Sudden, unexplained dyspnea. If you are not careful and you are not smart, you will never know this. This is where their story starts from. See a pulmonary embol. Pulmonary embolus. Okay. Embolus thrombus. It is one thing, clot. Layman's language, we call it clot. Okay. Clot. Yes. A thrombus is a clot. If this is the circulatory system, a thrombus is a clot that is stuck at one place like this. Okay. It is stuck at one, it does not move. That is what we call a thrombus T. But we have some clots that will be moving around. They move with what? The blood. Like if you go to the stream, you see that the river will be what? Moving some leaves, okay, along its journey. So it's the same clot, too, the same clot, but it's moving with the blood. We call this embolus. The name changes from thrombus to what? Embolus. A traveling clot and a stationary clot is thrombus. So a clot can build in your legs and will be stuck at one place. Or sometimes in the bloodstream in your legs, a clot will come and stop here. It is traveling, no. It is traveling like these guys. But when it got here, it is stuck. It is not moving again. The name changes from a traveling clot to a stationary clot. So if it is stationary and it is in your legs, we call it what? Deep vein. Depending on the type of vein it got to, because we have superficial vein and we have deep vein. So if it is in your superficial vein, we call it superficial vein or thrombus. If it is in your deep veins, we call it the deep vein thrombus. Okay, thrombosis. Good. So this clot has managed to travel from wherever it started from to your lungs. Okay, and it has got stuck there. It is not allowing any oxygen to go down. Okay, patient will be having what? Unexplained or dyspnea. Unexplained. This is where their journey starts from. Okay, this is where their journey starts from. Pleuritic chest pain. Pleuritic chest pain. How will you know that the patient is having pleuritic chest pain? They come from the word pleura. So we have the lung, and we have a certain clot that is rubbing around it, like the heart. There's a clot. So this is the lung, and this is the pleura, the clot. Okay. In between the lung and the clot, the pleura, there is a space. We have the pleural space. The pleural space. There is a small oily substance here. Okay. And God has connected the lymphatic system to it. So when the oil becomes plenty, it will drain out so that it will keep the normal level. Here is the case that this blood clot has come to stuck here. Okay, embolus. A lot of clots. You are seeing it here. Good. To make the fluid shift and accumulate here in the pleural cavity. So the patient breathing in and out, breathing in and out, breathing in and out. You are going to find what? A rubbery what? Pain, like something. When they breathe, when they stop breathing, the pain vanishes. But when they start breathing out, especially when the lungs, there are a lot of fluid here. So breathing in means that this lung that you are seeing here, it is going to what? Become big. And when it becomes big, it will push this water against the pleura. Okay. Yes. So when they breathe in, there are a lot of pain. We call it pleuritic chest pain. The person will say that when I breathe in, I have a lot of pain. But when I'm breathing out, the pain goes down. It means that when you are breathing out, the lung is going back to its original position. So the space increases. So the water there will not cause any issue. Yes. Okay. So that is another thing. Not all pulmonary embolytic patients experience this. Okay, good. The heart will try to help. It will send more blood, tachycardia, and tachypnea. Patient wants to breathe to send more oxygen, forgetting that this clot has blocked the way. Nothing is going down. Okay, so they begin to have what? low oxygen level in the blood. We call it hypoxemia. Yes. Then there is going to be more pressure here. The tiny capillaries, some of them, the blood pressure will go so high that it will start bursting. When it bursts, this fluid and this blood, they will mix with the air that is trapped here. The oxygen, remember, oxygen is here. It is trapped. Okay, so the water and the blood vessels and the oxygen, they will mix. We call it frothy. So these guys, when they spit or when they cough blood out, you see a lot of bubbles in it. We call it frothy sputum. Okay, frothy sputum. Yes. So all these ones you should know. Then some of them will collapse, especially the ladies. They will faint and collapse. They think that is the fear of an impending doom. Yes. Some of them to hypotension. Or this is an obstructive shock. Okay, so it will give them shock. Then possible unilateral leg swelling. Okay, how am I able to know that there are blood clots in the blood that is moving around the body? Okay, how am I able to know? We have a test that we do. We call it D-dimer. The D-dimer, when I take your blood sample, whether 5 mils, 2 mils, 3 mils, I take it to the lab, centrifuge, nicely. The machine will tell me that what there are a lot of clots moving in that blood, that small blood you took to the lab. There are a lot of clots. Okay. Can the D-dimer show us the stationary thrombus here? No, because the stationary thrombus, the stationary clot, it does not move. So, assuming how many nurses will go and tap blood from somebody's leg that we want to send it to the lab? No, you tap blood from the hand. Is this clot here? No. So the dimer will be 0. Okay. But for embolus, if some of this clot breaks and they are moving around the body, I can still catch it here and suck some and take it to the lab and do my D-dimer. Okay. But how will I, if I use D-dimer to catch the embolus, then how will I know that there is a clot in the leg? I have to do what we call the Doppler. Okay, or the venous duplex. Okay, yes, the venous. I'm scanning the veins to see a big clot. And when I see a big clot, I should know the size. Okay, and I should know the size of my blood vessel, the vein. Is it totally occluding it or partially occluding it? Simple. So this is a simple physiology that you catch it once and for all. Okay. Management. If you see this, and I've told you that this sign, no pulmonary embolytic patient can hide this. As I'm talking to you now, I'm not having dyspnea. I'm not having respiratory or shortness of breath. All of a sudden, I can't breathe. Nobody has hit my chest. Nobody has, stabbed me. Not all of a sudden, I can't breathe. Your patient, you are chatting, smiling with them. All of a sudden, okay, they can't breathe. You went to give IV line. This is where a lot of nurses, we get it wrong, okay? You gave an IV line. This IV line has been here for so many days. It has formed clot. People have good clotting factors. Okay. You went and connected your syringe. Okay. Instead of you to take this IV line or this clot out, you pushed it. You have changed the situation of a static clot to a traveling clot. How big is this clot? You don't know. But this clot is now going, it gets to the lungs, remembering that the lung has capillaries, that the size of these capillaries is tiny and smaller than that vein here. So this clot that was able to stay here without moving, when it gets to the capillaries, it is going to get stuck. So you think you are giving, oh, you went to hang antibiotic, you went to hang IV fluid. You hang the IV fluid within some few minutes, patient is complaining, I can't breathe, I can't breathe, I can't breathe, I can't breathe, I can't breathe. You think the patient is reacting. It's not reacting to the medication. You have changed the situation of this clot to this. Okay. So how many days should an IV line stay in a patient's body? Yes, send me your answer to the chat box. Okay. So you place on continuous cardiac monitoring and saturation monitoring. You give your oxygen, okay, as needed. You establish a new IV line or a large bore access. You do your EKGs, do your blood works, your CT, pulmonary. So we take a CT of the pulmonary angiogram, okay, or angiography. We are going to study the blood vessels in the lungs, which of them is blocked. Okay, then you prepare for your heparin. Heparin. This is an intrinsic problem. Okay, so you prepare for it. Then, yes, 72 hours, 3 days. Good. So IV line, peripheral IV line should stay 3 days, then you change. But because of workload, some patients will be wearing IV line for 5 days, 1 week. Nobody bothers. Not even dressing change. Okay. The massive or high risk pulmonary embolism may require thrombolysis. You need to break it down, okay? Or thrombectomy. Yes, so you can break it down with your heparins, okay? Or you can go inside CAT scan, go and take the clot out, or hot embolectomy, whichever way you can take it out. Then you closely monitor, because you are giving this heparin here, you monitor the bleeding time, okay, anticoagulations or the coagulation panel. Never massage any stationary clot. If you massage it, imagine you are holding a cube of sugar or salt, sugar, then you massage it. You make it tiny. You make it break into fragments. It will move with the blood and go and clot, cause stroke, cause anything. Okay? Good. Another respiratory emergency we see in the hospital. We have 1 hour to leave. Another respiratory emergency we see in the emergency we see is what? Tension pneumothorax. You see, I'm not talking about pneumothorax. I'm talking about tension. Okay, we are doing emergencies. So air enters the pleural space under pressure. Okay, we call it positive pressure. Anytime you hear the word positive pressure, it means something is pushing air from one compartment to another compartment. So things that will push things through holes, we call it what? Positive pressure. But if nothing is pushing nothing through any hole, or nothing is pushing anything from one space to another space, we call it what? Negative pressure. Okay, so as we are here, all our chest and our abdomen is sealed. God has covered with it muscles and skin, so no air is going there from anywhere apart from your nose and your mouth. Okay, no air is passing through anywhere and a force to to go anywhere. So for that one, we call it what? A negative pressure. It does not mean pressure is not there. Pressure is there, but it's called negative pressure. Okay, good. So when positive air enters, if this is your chest, this is my lung. Okay, and this thing. If positive air, let's say there is a stab here, and air forcefully pushes through this hole, the hole I talk about, it has moved, it is forcing itself. The lung is just like a sponge. Okay, sponge. When Oyibo says sponge, it's not the sponge we use in Africa. Their sponge is foam mattress. You remember that your foam mattress. Go and cut your foam mattress. Okay. Yes, the foam mattress we have been using it to clean cars and yes, to clean cars when you go to the washing bay. Those foam mattress, that is how your lung is. Can this foam mattress withstand this pressure? No, it will collapse. Okay, it will collapse. Collapsing means it will become smaller like this. You see your lung becoming like this. Then here is a lot of pressure air. Okay. Sometimes the pressure coming into the lungs is so severe that it is pushing the trachea away, shifting the trachea or mediastinal shift, causing a lot of pressure. How can the lungs expand? Or yes, so we call it what? Sudden severe dyspnea, sharp unilateral chest pain. They don't have pleuritic pain. Absent breath sounds, unequal chest expansion. We call it asymmetry. Unequal chest expansion, unequal chest expansion, tachycardia and hypotension. That is a sign of shock. Distended neck vein. Okay, good. Then tracheal deviation is a late sign. If you see tracheal deviation, this patient is dying. Then rapid progression to obstructive shock. Obstructive shock. Okay. But the pressure can mount in a such a way that it will even squeeze the heart. So we are not getting venous return. Okay, your preload will be in trouble. Okay, so what do? Emergency response. You give high concentration. So you have to banter. You have to counteract. Okay, you do have to give pressure, positive airway pressure through the mouth and the nose. Your ambuba, push against that pressure that is coming. So, like this, there's pressure coming here. Somebody got a car accident, a lot of air in the lungs. Okay, so what do you have to do? This is the mouth and the nose. You have to push pressure against it so that to move it back. High concentration oxygen as appropriate. Prepare for immediate needle, okay, or finger decompression. Then you prepare for chest tube insertion. Do not delay decompression for chest X-ray when clinical tension pneumothorax is strongly suspected. After you insert the tube, keep the drainage below. If you keep it up, gravity will let it flow back, and you're going to cause another hot pressure, positive pressure again. Then you check the tube for kinks. Okay, assess breath sounds, drainage site, and insertion site, or the drainage and the insertion, the chambers. Do not routinely clamp or strip it, okay, or milk the tube unless specifically ordered, okay, and permitted by policy. So these are the things you should know, okay. Eggles will test you on it. Tomorrow we are doing a big quiz on that. Okay, acute pulmonary edema. Where is the water coming from? Okay, it is often caused by heart failure, myocardial ischemia, or severe hypertension and fluid overload. I showed you a picture of this condition last week, so you should know. Okay, yes. So this is the lungs, and this is the blood vessels. Okay, good. And this blood vessel pressure becomes so high in such a way that fluid will shift, the plasma to shift from here to here, the space. So just like the clot that was talking here, this one, this time around, it is fluid that is stuck here. Okay. So oxygen again cannot go down. And patient will be having what? Severe what? Dyspnea. But this guy, the difference is that because it is fluid, if I have a container and I make the container flat like this, I pour water in it, I make it flat like this, the water will settle at this place. The water will not settle here and leave air. No, the water will settle here. If I make it vertical, the water will stay here and there's more air here. Okay, so your body now becomes a container. If you lie flat or supine, you have breathing difficulties because these blood vessels, they are coming, they have, but some will come here, okay, and some will go to the top here. These blood vessels coming from the heart, some will branch to the base, some will go to the middle. Okay, let me do a new drawing. So assuming this is your right lung, your right lung is divided into three, like I told you, the upper, the middle, and the lower. Okay, if I put the patient supine like this, the same division, the upper, the middle, and the lower. Okay, and the blood vessels are here. If they accumulate a lot of fluid here, it means that what? I cannot exchange oxygen and carbon dioxide here. Okay, I cannot exchange. Yes, some will also pass through the top and go. So the top I can exchange, but the down I can't. But I want more volume. So what do? I now position the patient upright like this. Then the same blood vessel. You remember that all the fluid that was covering all the chambers when the patient was lying down. Now, when I start the patient up, all the fluid has come to what? The lower chambers here. So it is only this chamber that gaseous exchange will not take place, but the middle chamber and the upper chamber, gaseous exchange will take place there. That is it. So pulmonary edema, position, and you drain the fluid. If I listen to the lungs with a stethoscope, I will hear a lot of fluid here, crackles, breathing in and out. I hear crackles. Okay. Yes. If the fluid is plenty, or if the fluid is plenty, I'll hear more crackles. We call it coarse crackles. If the fluid is not plenty, small, I'll hear small, few crackles. We call it fine crackles. That is it. So this is simple English. That they will use physiology terms to confuse you. And because of that, you don't have the interest to learn it again. And it will be worrying you. Okay. Hypoxemia, especially. Then remember, like the guy who was having pulmonary embolism, The pulmonary edema too will also mix, especially when the blood pressure goes high, to compensate. The capillaries will rupture. Okay, they are tiny, tiny, tiny capillaries. They can't stand pressure. They will rupture. They will mix with the fluid, get into the bases of the lungs. Somebody will cough it out. When you cough it out, imagine I mix blood, I mix water, I mix sputum, and I pour it in your stomach. Okay, you vomit. Because it becomes a foreign body. So in the lungs too, it becomes a foreign body. So you cough it out, coughing it out. You see there is air in it, pink, frothy sputum. Okay, okay. Anxiety, diaphoresis, all these things are behavioral modifications. Then hypertension may occur later. Okay, yes. If you see hypotension, it's a sign of what? Severe what? Failure. Okay, or shock. So what do you have to do? Always sit the patient upright with legs dependent if tolerated. Legs hanging, okay, not touching the floor, hanging by the side of the bed, not on the bed, hanging, okay, like you're sitting down. Then administer your oxygen, give your BiPAP and CPAP, you EKG, IV line, all these things. Administer nitrates. Nitrates will open up the blood vessels and the alveoli. You give your diuretic, your lases, but before you give your diuretics, know your blood pressure. Okay, yes. Then you treat the underlying cause. Then you prepare for intubation. Okay, good. Anaphylaxis. Anaphylaxis. Somebody has taken a substance and there's what? Respiratory reaction to that substance. What do you see? In reactions, depending on which part of the respiratory system is having reactions. This is my airway. The airway is divided into two, the upper and the lower. Inside the airway is mucous membranes. Okay. Underneath the airway is muscles. Here. Okay. I took a substance, I ate a peanut, I ate something. I'm getting airway or I'm taking antihypertensive medication like lisinopril, ACE inhibitor, is giving me angioedema. Okay, all these reactions are there. Okay, the mucous membranes will swell. Okay, and the muscles will go into spasms. And because it is anaphylaxis, it can even swell, the mucous membrane can even swell in such a way that it will even close my airway. If it closes at the upper side, you will hear what we call stridor. Okay. If you close it at the lower side of the airway, we hear what we call wheezing. Okay. Yes. So that is what, and hoarseness of voice. Tongue protrusion, lip swelling, angioedema signs, urticaria rashes, and flashing, sweating, minor sweat on the face. We call it flashing. Oyibo does not call I'm sweating. Oyibo will say I'm flashing. But back home we say I'm sweating. Okay. Then hypotension because of what? Vascular heart dilation as a result of what? Because the blood vessels will want to dilate so that they send more blood to the area of the reaction, allergic reaction. So hypotension. Then gastrointestinal symptoms may accompany respiratory symptoms. Okay, abdominal pains, diarrhea, vomiting, cramps, all these ones. Management, what are you going to do? If it is a medication, IV fluid you are giving, stop it. If it is a food the person is eating, they should stop the exposure, the triggering factor, stop it. You call the emergency response team because a problem is on the way coming or it has occurred. Give IM epinephrine promptly. A patient will come with a bee sting. Okay. There is one thing that Oyibo people cannot stand is that a bee will bite them. Okay. They can't stand that. They'll react. That is it is DNA, is nature. Unlike when you come back home, okay, people will walk to and go and harvest honey, bare hands, bare face, nothing will happen to them. Nobody will give them epinephrine. But Oyibo people can't do that. Yes. So you have to give them what? Epinephrine promptly. Okay. Then you position the patient appropriately, sometimes setting up position. Okay. Yes. But because of hypotension, avoid them standing. You give a lot of oxygen. Okay. Then IV access, big one for running of fluid to replace what or to correct the hypotension. Then you suction if indicated. You maintain airway. You can give bronchodilators to open the airway, okay, and antihistamine. So the albuterols, the Benadryls, the antihistamines, okay, yeah, diphenhydramine, and all this. Yes, then steroids to also reduce. So these are the things you do. Antihistamines and corticosteroids are not substitute for epinephrine. No matter what, epinephrine should be given. Please. Please, airway swelling may make later intubation extremely difficult. Okay, so correct the reaction with an epinephrine. Okay, no matter what. If your hospital doesn't have, they should have. They should transfer the patient to a different facility. Now let's look at foreign body obstruction. Children suffer this a lot. So if something goes past your voice box and it obstructs there, and definitely it will go past it and obstruct, your speaking will be gone. Check mark. You cough, you try to bring it out, it won't work. Okay. Yes, breathing will be ineffective. It can be brady or rapid or dyspnea. Cyanosis, central or peripheral. Okay, yes. So all these ones. So according to the American Heart Association, you give your heart the five for adults, 5 back blows, then 5 abdominal thrusts. Simple. So attach in between the shoulder blades. If this is, you turn the back of the patient. So this is your shoulder, your scapula, and this is your shoulder blade. Okay. This the bone that hold your shoulder. We call it the shoulder blade. Okay. In between, slap there with this hand. 1, 2, 3, 4, 5. Like you're pushing it up. 1, 2. It stimulates the coughing reflex because the coughing nerves. There are a lot of coughing nerves here. If you don't know, I'm telling you today. A lot of nerves that will help you to cough. They are in this area. So don't go and hit your the side of the patient here or here. We don't have a lot of nerves here. Hit here. Coughing nerves. 1, 2, 3, 4, 5. Okay. Then abdominal tract just under the diaphragm. You push it. Okay, you make a fist, then push it back up. 1, 2, 3, 4, 5. 5, 5. Patient will cough. Okay. If patient becomes unresponsive, don't keep holding them in that standing position or in that sitting position. Lie them down. Put them in the recovery position. Okay. Activate your rapid response. And if they become their heart stop and respiratory fails, CPR begins. Then You look for a visible object before giving hot breaths. Okay. And never perform a blind finger sweep. Never put your hands in any patient's mouth. Okay. Those of you who work in care home, that you go and give medication to people and put it in their mouth. Okay. Opioid. So we saw that opioid will cause what? Ventilation problem. Opioid does not block the airway. Okay. Opioid will work on the muscles and collapse it. So and also the respiratory center and collapse it. Okay, so carbon dioxide coming out of the body becomes the problem. If it doesn't come, it will increase and cause what? Acidosis. Patient will collapse, patient will lose consciousness and die. So their breathing becomes slow because the muscles are in big trouble, shallow, or sometimes absent. Reduce consciousness, that should tell you that the brain is getting involved. The pinpoint pupils. So if you see the needle that we use to sew clothes, look at the tip of that needle, not where you thread, not the eye, not the eye. The needle has two sides. We have the eye where you put your thread through, and we have the needle where that one goes through the clothes. The needle is just like this dot. Your people can shrink to become like this. That should tell you that this guy is severely intoxicated with drugs. So you do what? The opioid withdrawal assessment. We call it the cows. The cows. Okay. The opioid withdrawal. The saturation will drop, carbon dioxide will build up, and there is central or peripheral cyanosis. You should know the drug history. Ambulance brought them to the hospital, or opioid exposure, whoever, family members, they will tell you. So ABCD, airway should be opened, breathing, ventilation with the bag valve. Patient cannot do it, so help them assisted. And administer your oxygen. You give your reverser naloxone, very important. Give it. Then monitor for recurrent respiratory depression because naloxone may wear off before the opioid. Take note. So when you give your naloxone, the opioid, sorry, when you give your naloxone, the opioid will go and stand at one corner and be watching it. Some of them. Okay. So depending on how intoxicated and severe the condition is. Okay. Yes. So you check your blood glucose. I've told you that any patient in emergency state, whatever the emergency state is, your blood glucose, you should check it. Okay. You measure for head injury and stroke and all those other stuffs. Okay. Ventilation is the immediate life-saving action. Do not delay breathing support while waiting for naloxone. Very important. Opioid guys, their problem is bringing out CO2. So help them, put them on a vent. Okay. Yes. The ventilator will help you to bring the CO2. Then you connect the oxygen, depending on the mode, full control or whatever. Okay. Pneumonia and sepsis. Somebody has normal pneumonia. Okay. Pneumonia. We've done this over and over and over and over and over. Okay. Yes. So this is my lungs. Fluid has got into the lungs. Okay. Fluid I got into the lungs. I breathe air. I breathe air. I don't put anything, any object in the lungs. I breathe air. As you are listening to me, you are breathing air. Okay. This air has microorganisms, microbes that can follow the air to the lungs. If there is a bacteria among them, the bacteria, it does well. Bacteria swims. See, the best place for bacteria to grow and survive and enjoy life, okay, is what? A water medium, a place where there is fluid. So the bacteria what will grow. Today they are one, tomorrow they are two, tomorrow next they are three, they are four, they are five. So whilst they are growing, we call them incubation period. Every condition has incubation period. Okay. They incubate sometimes 2 weeks, 3 weeks. Okay. In adults, if you want to see that an adult is having pneumonia, eh, once a while, because of the fluid, once a while, if you are living with an adult, grandfather, grandmother, once a while, they cough, it will be consistent, then it will stop. Okay. Then they cough again, then they cough again, they cough again. Okay. These bacteria will be eating on the lining, breaking blood vessels and finding their way into the bloodstream. Oh, okay. So they find their way into the bloodstream and start causing what? Inflammations. Okay, in the blood, systemic inflammations. Yes, there's going to be a response, heat production, because of systemic inflammations, heat production, and increased metabolism. There's going to be more heat production. Can the hypothalamus control the heat that the cells are bringing to the system? No, they can't. Okay, so the hypothalamus will be overwhelmed, and there's going to be what? More heat, fever. Okay, as a result of this. So patient will cough in their sputums. Okay, there will be fever, sometimes hypothermia. There are crackles. Okay, low oxygen because of fluid, pleuritic chest pain. You see it again. Confusion, brain involvement, hypotension, lactate. Why is lactate a problem? Because of what? Low perfusion to the cells. This bacteria that got into the bloodstream, okay, they will now go and cause the capillaries, the cell membranes of the blood vessels to open up and fluid, the plasma will leave. So if the cells were supposed to get 1,000 mils, they are getting what? Only 200 mils. Meaning the oxygen level too has reduced. Meaning cells has less oxygen for it to work. So cells will now depend on anaerobic respiration to produce ATP. Okay, a lot of acid will be produced as a byproduct, causing what? Acidosis. So you see your lactic acid increasing at the cell level. How can I do this? I need to push more fluid because the cells are not getting fluid. I need to push. Why? Because the fluid, the plasma that is supposed to come here, it has drained out. So I need to push more fluid down. What IV fluid will I give? Your Ringer's lactate and your normal saline with electrolyte in it. Perfect. You are done. So oxygen, your blood cultures before you even give anything to the patient. You give your antimicrobials promptly. You administer your fluid cautiously with 30 mils per hour. Okay. Then you monitor for sepsis, ARDS, that is severe form or respiratory failure. Then escalate support if oxygen requirement rise. On this note, let us enter into a state we call acute respiratory distress syndrome. If you have never managed this case before and you get it, the patient will die on you. Okay, yes. So as the problems of the respiratory system keeps compounding, let's say somebody has pneumonia. Today they take treatment, halfway they stop. The infection will come again. Okay, yes. This is an acute, the respiratory system will assume an acute inflammatory lung injury state. Okay, imagine pneumonia injuring your lungs. You are not giving it much attention. It will keep injuring. Oh, today you come and take antibiotic, tomorrow you start this, temperature will go down. Oh, I'm fine. You go to the football pitch, you are playing ball. Okay. Yes. Or you are on the ward. Okay. They are not treating the patient well, they are doing this. Okay. The lung injury will be causing, it will be ongoing. The bacteria, they don't care whether you take your medication or not. They are eating your lungs, causing non-cardiogenic pulmonary edema. Okay, non-cardiogenic pulmonary edema. Yes. So you see that the cells, the water in the cells will now move to the lungs, but the water in the blood vessels will move to the lungs, okay, and cause severe pulmonary edema. Are we having any heart failure? No. Do your EKGs normal sinus rhythm. You do your chest rate X-ray normal heart. You do everything, but it's as a result of what? Severe. So if, oh, sorry. Why do I always do this? If pneumonia is giving you 30 mils, ARDS can give you 500 mils of fluid sitting in your lungs with lung injury. They are chewing your lungs with a lot of fluid accumulating there. Okay, so you get severe pneumonia, aspiration. Some of the causes: aspiration, major trauma, pancreatitis, inhalation injury. Okay, so how are we going to see? Definitely, there's going to be what bilateral crackles. Dyspnea is getting worse day by day. So patient will say that for about 2 weeks now, every day I'm having issues with breathing, shortness of breath, all these things. Okay. Yes, they will come to the hospital unconscious. Bilateral lung opacities. Hypoxemia may respond poorly to ordinary oxygen. Okay, yes. And increasing respiratory support requirement is very important. So how are we going to treat this patient? We have 30 minutes to go. How are we going to treat this patient? You treat the underlying cause. Yes. If pneumonia, kill the bacteria with your antibiotics. Okay. Your oxygen, yes, there is lung issues, lung injury, but sometimes the lung, if you want to take the lung, this cloth that we are wearing, you can take a blade and cut the thread out of it, and it will become 1 yard, 2 yard, 3 yards big. If you take a blade and you want to cut the connections of the lungs, it is the size of a football pitch. Can one bacteria, the size of a football pitch, this is your lung. So if you have 50 bacteria, okay, can they chew all this pitch within 2 weeks? Yes, if you don't take it serious. So they will start chewing. They are chewing. They are chewing. They are chewing. They are chewing. While they are chewing, remember inside the cell, there is what? Fluid. So it will be draining inside. The blood vessel to fluid will come. But this patient does not have hypertension. It is non-cardiogenic. They don't have ventricular failure. Okay. But they are always complaining of what? Shortness of breath. Shortness of breath. Shortness of breath. Shortness of breath. Yes. So what do you do? Bacteria are chewing. They are chewing. They are chewing. They are chewing. Some people will sit down for bacteria to kill them. It means they finished your lung. Okay. That you have gotten to a state that a lot of people die from sepsis, acute respiratory distress syndrome. Okay. Yes. And this one will suddenly occur that it will shock you. It will give you the shock of your life. Okay. Good. Smoke inhalation or airway injury burns. The patient will come, they have neck burns, soot around the nose, the mouth, singed. If you look at the nose, singed. So when you say singed, a hair that half has bent, it's called singed. Okay. Hoarseness and stridor. Okay. And carbonaceous sputum. Carbonaceous sputum. Yes. And confusion, headache, or sometimes they collapsed. You found them collapsed in an enclosed fire space. Okay. So what is the management? 100% oxygen, airway, upper airway. Remember that pulse oximeter or oximetry, this red blood cell, the hemoglobin in it, yes, it loves oxygen, but it loves carbon monoxide. That is why we have what? Carbonaceous sputum. Okay, dark sputum. Very dark. Sometimes blood in it. You take it to the lab for analysis. Carbon monoxide concentration is very high. Okay, so when this carbon monoxide CO gets into the bloodstream, this one quickly binds with it. So you see what? Your oxygen level, saturation levels 100% consistently. It doesn't drop. Even if it will drop not below 98. A patient who is unconscious with this saturation, it doesn't drop. Really? Okay. So what do we have to do? We have to counter it. I say when somebody gives you pressure, give higher pressure. So you give more 100% oxygen. Okay. When carbon monoxide poison is suspected. Then remember that pulse oximetry may appear falsely reassuring in carbon monoxide exposure. Then obtain core oximetry or carboxy hemoglobin testing. You check that pattern to know that okay, how is the hemoglobin carbon monoxide binding with the hemoglobin? You know, there's so many tests they do. Okay, prepare for early intubation before airway edema worsens. Okay, then you consider cyanide toxicity in severe enclosed fires, especially people who work in factories. Cyanide. When cyanide binds with your blood cells, you are in big trouble. Okay, serious poisoning. Okay, right. So, guys, these are the major respiratory emergencies that we can encounter in the hospital or whichever environment we find ourselves. Okay. Essential investigations you should do: your pulse oximeter, your blood gases, end tidal CO2, if patient is intubated or using airway devices, your chest x-ray, your EKGs, 12 lead EKG, and continuous heart monitoring. Okay, your CBC, the electrolytes, and glucose. Your lactate and the cultures, blood cultures, okay, to help with infection. Your respiratory viral testing, very important. Your troponin and BP to rule out cardiac issues or to confirm cardiac relations. Your D dimer to know the traveling thrombus, okay, or traveling clots. Your CT of the pulmonary vessels, CT pulmonary angiography for suspected pulmonary embolism. Then bedside lung and cardiac ultrasound. Okay, yes. So when the ABG comes, ask yourself, what is the pH? Check this is to help you to know, is it type 1 or type 2 respiratory failure? Okay. So what is the pH? Is the pH acidotic or alkalotic? Okay. Then you check the partial pressure of carbon dioxide. Yes, for the respiratory issues, respiratory failure. Okay. Then your bicarbonate, if you want to know if the cause is coming from, let's say, Cushman guys, diabetic type 1, DKAs, and all those ones. Okay. Yes. Then you check the partial pressure of what? Oxygen for oxygenation, oxygen going to your body. Type 1. Okay, type 1. Okay, determine whether compensation is present or not. So we have all these combinations that we do, but me, I won't learn this. But if you want, you can learn. I added it because when I get ABG, I know how to interpret and I know what to do. Okay. Yes, I don't learn this is robotics. Okay. When we put A plus B, we get AB. And we do C plus D, we get CD. And you get 1 plus 1, we get 2 by force. Okay. So when we change the story for you, you'll be standing there. Other than that, it works. So somebody will come with a low pH with a very high hot CO2. Okay, respiratory relations. A high pH with a low CO2, carbon dioxide level. We call it respiratory alkalosis. Okay. Rising pH, drowsiness, worsening hot, ventilatory failure, then low oxygen in blood, hypoxemia. Okay. So preparing for intubation, especially if you work in the ER, these are the situations that we can intubate a patient. Patient with apnea or respiratory arrest, inability to protect the airway, a lot of secretions. Patient is having a lot of secretions. You suction, but still coming. You suction, but it's still coming. Secretion, suction. This patient cannot maintain airway. So let us now put a tube down. Okay, yes, we put a tube down. So we have some ET tube that has a suction port connected to it. So you suction and the airway. You can do another job. Okay, there are so many things to do within the 12 hours. Then severe hypoxemia despite minimal non-invasive support. Okay, worsening hypercapnia with acidosis, exhaustion, decreasing respiratory effort, severe altered mental status. GCS is dropping below 7. Okay, intubate. Progressive upper airway swelling, asthmatics, allergies, intubate. Hemodynamic instability, your preload, your afterload, your blood pressure, or all these ones, Okay, respiratory failure. Good. As a nurse, don't do it alone. Okay, call the respiratory therapist. They will come and intubate the patient. They will come and use the bypass. They will help with the ABG analysis. You have care that. Okay. A. So B. Breathing oxygen. Is there oxygen in the tank? Everything bagging. Okay. So mostly the A side, the airway side, the anesthetist or the respiratory therapist will do. The B side, the nurse must do. Okay. Your oxygen, your ambu bags, your difficult airway equipment. Okay. Then the cardio, the C side, your ECG monitoring, you put it there. Your 12 lead EKG, you do the IV lines, you do the blood draws, you do the blood pressure, the pulse monitoring, you do. Okay, the IV access, large bore, you do your medications, okay, disability already. Patient comes, you have done your AFPU, you know. So what are we doing? Medication wise, what are we doing to bring the reduce deterioration? Okay, the pre-oxygenation, you confirm ET tube placement with what CO2 coming out through the capnograph or chest X-ray telling us that we don't have endobronchial intubation. Okay, yes. Secure the tube and document depth. Obtain post-intubation imaging. There's the chest X-ray. Then start sedation and analgesia as prescribed. Those who will be working in ICU. This patient is going straight to ICU. No other department in the hospital. You monitor your ventilation, hemodynamics, and tube positioning continuously after everything. Okay. Never treat a respiratory emergency case and leave the patient. Madam, you are well, go home. No. A severe asthmatic crisis. They came. Now they are, oh, I can breathe, everything is fine. Okay, go home. COPD, I can breathe, oh, everything is fine, go home. No. We say never treat and leave. That's the clause. So after all your interventions, you continue your reassessment. You reassess everything we have done. The medications, they did work, the mental status, the heart rate and blood pressure. You can keep them for observation at the ward for 1 day or 2 days. Okay, yes. Then you do your proper documentations, medications, response to treatment, and all those ones. Okay, yes. So I added the high yield clinical distinctions for you to know. If you hear your stridor, you know where the problem is. You hear your wheezes, you know where the problem is. You hear your silent chest, the bilateral crackle. So these are combinations that you should know. Now, NCLES clinical priority rules. Okay, we have 10 minutes to leave. Airway comes before oxygen delivery. If ventilation is inadequate, oxygen alone cannot work, is insufficient. So the fact that you are seeing a higher SpO2 does not mean the patient is bringing out CO2. You should assist, put the patient on ventilator, assist control. Okay. Stridor is generally more urgent than wheezing, upper airway, very important, especially choking. Okay. Then a silent chest in severe asthma is worse than loud wheezing. Treat suspected tension pneumothorax immediately. Do not wait for the imaging. So you tap, needle stick, needle tapping or finger. In anaphylaxis, okay, a cat, animal, whatever, bee, whatever, I am epinephrine in the thigh, okay, you give it, okay, or where there are muscles, give. Then you monitor the patient. When you give epinephrine, most of the time, the place that you injected the needle, okay, you give the IM injection, that place will become red. please, that is not allergy to the medication. So NCLEX will come. A patient after collecting or getting IM epinephrine start complaining that there is a red spot at the site of what injection. This is a normal, means that the medication is working. Okay, it's not allergy to the medication. Okay, so sit conscious dyspneic patient upright unless contraindicated. A new confusion may be a respiratory sign. Give control oxygen to COPD. You know the physiology now. And reassess after every intervention is essential. So your ABCD, please, everything we have done, this is the summary. Rapid bedside, airway. If I were you, I go to work, I ask myself, my patient, airway, what will help him? If suddenly the patient goes into respiratory attack, airway, what preparation have I done? Okay, yes. So you position your patient, open airway, give oxygen, then your reassessment and patient response, the GCS, and that's it. We are done. Right. So yesterday when I was at work, okay, I took my time to go through the new NCLEX. So this is the curriculum. It is for, we are going to use it for the next 3 years. It will end on 31st March 2029. Okay. This is official report from what? The NCSBN. I'll get a day and explain everything to you, what you are supposed to do. These are the areas they are going to test us on. Management of nursing care. And these are the topics you should know before you enter the NCLEX room. Okay. Safety and infection prevention. These are the topics you should know before you enter the NCLEX room. Health maintenance and promotion. These are the topics you should know before you enter the NCLEX room. Psychology now, before it was psychology, psychiatry, but now they've changed the name to psychosocial integrity. So these are the topics you should know before you enter the NCLEX room. Basic care and comfort. These are the topics you should know. Basic nursing before you enter the NCLEX room. Okay. Pharmacology. These are the areas you should know before you enter the NCLEX room. Reduction of risk potential. These are the areas you should know before you enter the physiological adaptation. These are the topics you should know before you enter. Okay. Then clinical judgment. So before clinical judgment was just one topic, but now they've broken clinical judgment into what? 6 topics. So in all, it is 8 areas that they will test you with the NCLEX. By clinical judgment alone, they've subdivided it into another 6 areas. Six, I think 6 or 7. So in all, you are getting like 14. So clinical judgment, the measure skills, they've added what? They will now test you on recognizing cues, your ability to identify the cues. That is why we are doing the emergencies, the system emergencies. Okay, the cues. If you're able to recognize it, your ability, they will test you on how to analyze cues. Okay. Then after you've analyzed the cue and know that, okay, this one is asthma. Okay. How the signs and symptoms the patient brought, all asthmatic emergency patients will not come with one sign and symptom. Every patient will come with its own signs and symptoms. Okay, like a heart attack, males will come with their signs and symptoms. Females will come with abdominal pain, no chest pain, but they have heart attack. Okay, Yes, so you prioritize your science and symptoms, your labs, your vital signs. You prioritize which one should I start first, okay, and time constraints, okay, very important. Then, in nursing, in nursing, if you look at the art pie, if you look at the art pie, okay, we have the planning. Okay, now they've changed the name planning to generate solution. So they will ask you what is the best intervention, what is the appropriate intervention. Those questions you will see this English. Okay, so we don't call it planning again. Generate in solution. So if you wrote NCLEX and you did not pass, you go and see a topic like this on your test report. Generate solutions. Then the implementation on the AdPi is now changed to take action. So the implementation and the interventions that you address, then the evaluation of the outcome. So everything is here. Okay. Everything that you need to know is here. Okay. So let's see. They've also made changes to give me 5 minutes. Let me go through this with you guys. I won't take long. So in all, they said each candidate will answer between 85 and 150 questions according to their official website. If you click here, it will take you straight to the website. Okay, within a maximum of 5 hours. Okay, before, if so, the minimum you can answer is 85. If you don't finish the 85 and the 5 hours you elapse it, is failure. Okay, now let's interpret what happens. So somebody answered 85 questions, or when you answer up to 85 questions, this is the earliest the computer can stop and determine pass or fail. Adaptive ranges. If computer does not stop at this phase, now they say from 86 to 149, the last but one question, the computer can stop anywhere. So put in your mind, if your computer does not stop at 85, it can stop anywhere. So the computer continues until it becomes sufficiently certain. Okay, so sometimes they only need maybe basic care and comfort for you to pass, but you did not prove yourself. 150 questions. Okay, good. Now, when the computer gets to 150, the computer will make its final decision. And the time allowed is this. Okay. Then, so what is inside the minimum 80, your first 85 questions? At minimum length, they will test you on what? 52 questions will cover all the 8 areas. And 18 questions will form 3 clinical judgment cases. They will choose 3. They've divided the clinical judgment. And 15 questions are non-scored pre-test questions for the next 3 years. So out of the 85 you are doing, 15 questions, they are not scoring you. So your life depends on these 2. Okay, good. You cannot identify the 15 non-scored questions. They will not tell you that this question is you are scoring or not. So every question must be treated as scored. Okay, this is the point that it matters me most, how they are going to do it. So they said the 3 stopping rules. When the computer stop, the 3 stopping rules that you should know. Okay, rule number 1, they call it the 95% confidence interval rule. So what does it say? After you answered at least 85 questions, the computer will now ask,
Am I at least 95 certain that this candidate's ability is above or below the passing standard? So if the computer is 95% certain that you are above, the computer will cut and you pass. If the computer is 95% certain that you are below, the computer will cut at 85 questions, then you fail. But if the computer is not certain, you are in between pass and fail, it continues giving you questions. Therefore, the examination can stop at 85 because of either a pass or a fail. Okay. The second rule, this is the first rule they are going to use, their marking scheme. The second rule is the maximum length rule, because people are complaining that we did not finish and the time elapsed. We did not finish and the time whatever. And some too, some people also came out and said that, oh, I did all the 150 questions. Okay, how would the computer also look at those who did 150 questions? If your performance remains very close to the passing standard, the computer will keep giving you questions until you get to what? 150. So 85 questions, they will assess you. Are you within the 95, above standard or below? Okay, you are near, you are in between. Let's continue. 86, it will reassess. 87, it will reassess. So each question they give you, it will reassess, to reassess. So when you get to 70 and you are above, averagely, you pass. Computer will pass. It can stop anywhere along the way. Okay. So at question 150, that is the final estimate, ability estimate at or above the passing standard. So if you answer 150 questions and generally or averagely you are above, you pass. If you are below, that one no issue, you fail. So the 95 setting rule is no longer required once the maximum number has been reached. So that is what. And the third rule I want to explain to you before we go is what we call the run out of time rule. Now they are more liberal. If the 5 hours expired, fewer, you did not answer 85 questions and the 5 hours expired, your time ran out, it is automatic failure. Okay. But if at least you answered 85 questions and your time ran out, the new rule says that the computer uses your final ability estimate. Okay, example, if you got to 90 questions or 87 questions and 5 hours went out, okay, they are now going to use the 90 questions you answered to ask, among the 90 questions, are you above or below? If you are above, you pass. If you are below, I think this is a fair rule and I support it. Okay, so that even gives you the time to what? To take your time and answer the questions, understand the question, but make sure you cross the 95 and the 85 before the 5 hours is over. Okay, so they are now using what we call the 0.00 logic. I mean, the standard deviations and all those ones. Okay, yes, so all these rules are here. So they give you a simple example. If the computer stops at 85, it has already become 95 certain that you are either clearly above or below. If example, if your question cut at 120, 112 questions, it needs additional information. It means the computer needed additional information. And at this question, after this question, the computer reached 95% certainty after whether you have passed or failed. Then 150 questions, that one, the question doesn't have any extra question to give you again. The computer doesn't have any extra question. So it will make its final decision whether you pass or fail. You fail. So, guys, this is the new rule. Go with it. Thank you so much. Let me leave you. It's 4 o'clock. I'll be going back to work tonight. So tomorrow we have a quiz to do. Okay. You can sit down and kill this. Kill it all. They are not certain. They have said that we are not doing anything outside the curriculum. Okay. So your life is in your hands. Thank you so much. This is what I can do for you. If you don't learn, please say, can you send these rules to us? Oh, I'm preparing notes on it. So when I finish, I'll send it to you, okay? Don't worry. I'm preparing notes on that. Okay, so now that is how we are going to go. So I think we have done, we have done physiological adaptation on this slide. The slides are there. Basic care and comfort, we have done the part A. Let's with the part B. Basic care and comfort is Charlie anyhow. Then we have done psychosocial integrity with the ATT class. We are done with it. Okay. Then what else have we done? We have not done clinical judgment. We have done management of nursing care. We have done it. She said, where are you from? Hey, I'm from Ghana. I'm a Ghanaian. Yeah, so thank you guys. Okay. Go and learn. Go and learn. The slides are on the page. Those in the ATT groups, please send the psychosocial integrity slides to the main groups so that people can benefit from it. But I think I will have to go through again. Okay. Oh yeah, Victor, I'll send the slide to you. Okay. If you have not liked this page, if you have not subscribed the channel, like it. Okay. Yes, you use Amasa a lot in clinical judgment. So go and look. Or you want me to prepare a new listing on Amasa, a new note. I can do it for you. Maybe one Saturday, if nobody's going anywhere, we take some 2 hours. Then we come and do Amasa. We learn Amasa. Then we do the application. Okay. Yeah. So, yeah. So please follow a pattern. Follow a pattern. Okay. Get time for yourself. All these things we are doing, you have to get time for yourself and learn. If you don't get time for yourself and you don't learn, you'll be jumping from one group to other. You think you are learning. You're only a listener. You're not learning. Okay. You are only listening. So until you get time for yourself to develop your own strategy of learning, you have to personally, God has given you the ability to develop your own learning strategy. Okay. So until you see it, passing exams will be difficult. Learn, and know your strategy to learn. If you catch your strategy, life will be simple. That will make that is what we call talent. You have your strategy of learning. So go sit down. It takes constant practice. And remember, failure is part of the success journey. Okay. Yes. Failure is part of the story. So if you fail, I know people have gone through so many platforms. People have tried to study on their own. They have failed. They have done this. Okay. Some people did not take it serious at the first instance. Some too wanted to go and see how the necklace looks like. So the first attempt, they just say, "Oh, let me just do anything. Let me go and try my luck." Okay, and it works. Somebody will go and try the luck. You get cheap questions and pass. Some too go and try the luck. Okay. Oh, thank you, Ruth. Some too try their luck, and it worked. Okay, it didn't work. Okay, so sit down, ankles until you sit your bum down, your buttocks down, and learn. It will be difficult. Okay, I believe in luck, but I don't prioritize hard work over luck. Okay, I prioritize success, talent, gift, talent, natural talent over hard work, and I prioritize hard work over luck. That is my hierarchy. So the guy who is talented, no matter how you train or how you practice, he will find it easy to grab and go his way. Okay. Yes. Unless he decides not to use his talent. It does not mean that hard work you will not succeed. You will succeed. But if the one with talent wants also to become hard worker, that person will go far than you. That is natural. It is God who arranged it that way. So don't envy anyone. Okay. You too, you have your talent. Go and work on it. Then lack. Never put in your mind that this thing I'm doing, I'm also considering lack. It should be your last option. Everything you want to do in life, don't think about lack. That let me do half. Another person will also come and help me with half. That somebody, I will now ask somebody to come and help me with. That is, you are depending on luck. Okay, don't depend on luck for anything. Work for it. If you fail, failure is part of the journey. Okay, failure is part of the journey. The failure will bring the strategy. If you don't know, I'm telling you, write it somewhere. Failure will bring the strategy. If the failure does not, or failure will sharpen, you have a strategy, but failure will help you to prune, to carve the strategy. That no, this one, I should have done it this way. This one, I should have done it this way. This one, I'm not going to do it again. This one, okay, let me add new one. It helps you to carve, to prune your strategy, failure. So that, oh, okay, I need to learn it this way. I need to catch it this way. I need to, yes. So, guys, thank you. We are not spending more time. Okay. You've done 16 minutes above our 3 hours. Okay. Which is fair. And it's for our own. I'm not talking much. See you tomorrow for your this thing, your questions. Okay. On respiratory emergencies. So tomorrow be ready. Calm shift. Thank you so much. Hey, one another thing. So, when I'm not working, when I'm off, I would like to do it at 2 hours earlier. So today, like this, I'll be going back to work. So I did it the normal time. That is 1 p.m. my time. Then we do 3 hours. So tomorrow evening I'll be working. So we will do it like today, 1 p.m. I don't know the time at your end, but the time at my end is 1 p.m. Okay. So the time that we started, go to the page, the time that I posted or Ayariga posted the link, that is the starting time for tomorrow, 1 p.m. Okay. But from Wednesday, Okay, Wednesday, after Wednesday, I have 8 days off. Okay, God willing. So that one, if I'm off, we can bring it 2 hours earlier, 11 p.m. to let's 11 a.m. to 1, or we can maintain. I don't know when Nicholas will be back. Okay, so I've told him that when Nicholas comes, he will handle the ATT groups. Okay, then myself and Ayariga will handle the main groups. So you start afresh. I'm preparing slides for all the NCLEX areas. So now we are not going to do a system by system foundations of nursing. Today, Yari Negede, Philly Gadochi, you have seen the curriculum. So you should realign yourself how you learn. Okay. Yes. I'm better than you, I'm not than you. Thank you guys. God bless you. See you again next time. Okay. Good. Thank you so much. Remember to subscribe, share the channel, invite more people. Our aim is to help more people. Okay. Our aim. And I've spoken with two of my guys. I was with them in UK, and we are now working in the same hospital in Rochester. Okay. Yes. One is very good with auto. He works in the auto. And one is very good with emergency care. Okay. So I have asked them to select topics. Okay. So one day I'll host a live with them on maybe TikTok or even Facebook. Then they will take a topic, then they will present to you. Okay, let's say after I told them I'll give each one 30 minutes, 30 minutes. They should present so that if you have questions, we are not going to go more than the 3 hours we do. So 30 minutes, 30 minutes. So they will pick one topic, submit how to prepare. Okay, and please, can we finish the crash course? Okay, no problem. Okay, yeah. So they will do the presentation for you. Okay, but it's not going to be on YouTube. Maybe the ATT group. I have to, me. I like respecting office. Okay, if I give somebody office, if I give a duty to someone, I want the person to do it and feel it that yes, I am in charge of this office. That is why I've given that responsibility to the ATT admins. Okay, Olubumi and Nicholas. So if Nicholas comes, they will continue. Okay, even if I prepare the slides, they will continue to teach. So that they will also have authority there. Then myself and Ayariga, we are also doing the main pages. Now we have even added nursing training, those in the nursing training schools. Yes. So they join and they learn. So yes, you didn't know, but we have a nursing training page, P Bright Education Consult. We have a nursing training page with a lot of people on it. Like when you go, there's only nursing training students. They join our live and they watch. And we have also opened the two main pages are full. I know people were swimming from this page, jumping from this page to this page. Okay, so we have opened a new page. Yes. So please, thank you so much, guys. Bye bye. I see you when I see you.